please. And may I also invite Dr. Ashok sir to kindly chair the session. We have Dr. Gyan Ranjan, if, or, okay. And may I have invite the first speaker, Dr. John Moore. So Dr. John Moore sir will be speaking on approaches. So direct anterior, Dr. Patel will be speaking on it tomorrow. But uh, there are so many approaches. Like I do anterolateral, I do DA, I do posterior. But direct superior, let's hear from Dr. John Moore, sir.
Thank you. After complex talks like robotics and then revision neglected hips, we're going to give your mind a little bit of a break and go back to do some hip approaches. So it's my honor to be here today. I don't get to wear my elephant tie very often, so this is a great time to break it out. So I'm from Florida State University in Florida, United States, near Disneyland. And there, we don't do anterolaterals, although I understand it's the gold standard here in India. We don't do lateral or anterolateral because it's pretty much considered that because of violation of the abductor mechanism, it's a no-no. So we basically don't do that at all. So what does dictate a surgical approach? Obviously, it's what we've been trained in, what you prefer, what feels comfortable to you. You can do surgeries through any single approach, whatever makes you feel better. Prior incisions affect that. Obesity is tough on incisions. For example, anterior has a big pannus sitting over the incision site, and it's always up in that crease. And the wound healing problems, infection rates higher there. The risk for dislocation is purported to be higher in posterior, although I might argue that. Implant selection, for example, anterior, if it's hard to get the femur up, you have to have a little bit of a shoehorn, short stem, and so some people prefer to, if they're going to use a short stem, to go anterior, and then deformity can do that as well. So the three we're going to talk about briefly today are superior, anterior, and posterior. For some of us, maybe superior is a new approach. It's not really so much, but here we go. So I trained on this a long time ago. It became increasingly popular. Good long-term results. The first publication was in 2008. Actually, it's kind of like a posterior, kind of goes through the gluteus, and then it goes between piriformis and gluteus medius to enter the joint. The advantages are that there's no surgical dislocation. So you do this procedure with a femoral head in situ in the acetabulum, which then lets you have a diminished dislocation rate because you leave the capsule pretty much alone. The external rotators, the ITB, those are still on. You just make a superior capsulotomy, and it's really easy to put it back together at the end, and so you have an intact cuff of a capsule. And then it's a familiar position because this is what posterior hips look like, lateral positioning. There's no special table like the Hanna table that people use for anteriors. There's not much femoral fractures like anterior because you don't have to torque on the femur so much, and you don't violate the abductors like the lateral approaches. And pretty much there's no difference in gait when you're done because you don't violate anything that affects that. There's a learning curve that's very minimal. It really takes 2 or 3 cases to learn how to do this approach. It's very obese friendly because the adipose just falls away from the incision when they're in the lateral position. There's no numbness and tingling like anteriors. You don't get the sciatic nerve like in posteriors, and it's easily extensile all the way down if you break a femur or something in the middle of your case. So the disadvantage to me is I like to get an intraoperative radiograph to see exactly where I am, and of course you're in a lateral position, you have a big oblique view there, and it takes a lot of maneuvering to get a true AP that you'll be measuring post-operatively. That's the single biggest disadvantage to me. Now the direct anterior is exceedingly popular where I'm from. It's a big marketing event, and it became to be that if you didn't do anteriors, you really were committing malpractice, and that was the only way to do a hip. So there are good long-term results. It does use the interval between the tensor fascia lata and the sartorius. The reported advantages are there's a decreased dislocation rate, but only relative to posterior. And I would argue that in my career, I've done more posteriors than any. And if you repair the capsule meticulously, the dislocation rate's not very high in posterior. Further, if you have an anterior approach, you can both dislocate anteriorly and posteriorly, which is a new concept. And mostly when you do a posterior hip, you only dislocate posteriorly if you're going to dislocate at all. But the abductors are not violated. There's no change in your biomechanics of your gait. And it's really simple to do an intraoperative AP radiograph check to see where you are. So that's a real advantage. Purportedly, you have decreased muscle damage because you do go between muscles, but you still take down soft tissue relative to other approaches very similar. The decreased pain, quicker surgery, good. Don't know that that's necessarily true. I think that all three approaches that I do are roughly the same, but that's the marketing is that you have that less with the anterior. So the disadvantages are a lot. Even though it's a hot item, it's purported, there's studies that show that the learning curve is over 100 cases with the anterior approach. That's ridiculous. That just means there's inadequate instruction. It does not take you long to learn how to do this case. I actually went to 5 different centers to watch surgeons that were good at doing this do it. I still didn't know how to do it. So there's a way to not be able to teach this well. And there's a fracture risk because you have to lever on the femur to get it up and out of the incision, and that's a known entity. Surgical site infections go up because the incision's right there under the pannus, and you're operating right into the inguinal crease, which is a sweaty area that doesn't heal well. The femoral exposure is the whole case. Getting the femur up and out of the wound so you can access the femoral components the whole case. It does take some retraction. You can break off the greater trochanter, or you can drive the component out of the femoral canal. Some people use a special operating table, HANA table. It's called where I'm from. It's cost $1 million US. It's ridiculously expensive. There is a chance of getting a lateral femoral cutaneous nerve paresthesia because it's right there next to your incision. And it's not uncommon to have a numb anterior thigh unless your patient knows about that. They're not very happy. Even if you do tell them about it, they're not very happy. And then plus there's a circumflex artery that you must take down. So even if you cauterize it or even if you tie it off, that bleeds sometimes after surgery. And it's one of those things where some surgeons even put drains in anterior hips. Now the posterior approach is what I was brought up on anyhow. And it's the most common where I'm from. There's no true interval. You just go through the gluteus. You don't violate the abductor. There's excellent exposure to both the femur and the acetabulum. It's easily converted to an extent-style approach, and it's familiar to everybody. But the dislocations, the bad rap about posteriors was that it dislocates out the back, and that's mostly because people were taking out the capsule or they weren't repairing it adequately. And so every time that people got in an extreme position, it just popped right out. And sciatic nerve palsies and sciatic nerve injuries are not unheard of after operating with it right in your operative field. And then, of course, there's the extensile approaches like the ETO. And the advantages are that it's useful for primary and revisions. You get excellent acetabular exposure. It's useful for component removal when it's cemented way down the shaft or somewhat. But there's a huge amount of complications, non-union heterotopic ossification. You get bursitis, abductor weakness. And it does take a long stem that bypasses where your ETO is. So big stuff going on there. In summary, your THA approach is basically what you like. You can do any of these procedures through any of those approaches. Consider the superior something relatively unheard of. And then consider prior incisions, obesity risk for dislocation, your implant that you're going to be using, and then, of course, the deformity you're going to have to deal with. Thank you very much.
Thank you. Our next speaker is